Bonjour à vous tous. Good morning, everyone. My name is Sharon Squire, and I'm a National Director for Ottawa of the National Association of Federal Retirees. And I'm pleased to welcome you to today's webinar entitled Alternatives to Medication for Treating Mental Illness, presented by the Royal. I also serve as the chair of the Board of Trustees at the Royal, so I'm pleased we can share some of our groundbreaking work in mental illness with you. And welcome to our Ottawa NAFR members and those who are not yet our members. We hope these webinars will inspire you to join our association. Before I begin, I'd like to recognize that the Ottawa branch is located on the unceded territory of the Algonquin Anishinaabe peoples. We extend our respect to all First Nations, Inuit, and Métis peoples for their valuable past, present, and future contributions to this land and country. I'm also pleased to welcome our presenter today, Dr. Sara Tremblay. Dr. Tremblay is an associate professor at the Université du Québec en Outaouais and is a licensed neuropsychologist. She is also the scientific director of the Neuromodulation Research Clinic at the Institute of Mental Health Research. In today's presentation, Dr. Tremblay will explore the promising future of neuromodulation, a non-invasive technique used to help relieve symptoms of depression and other mental health conditions. Her research is opening new possibilities for treatment and care for individuals who haven't responded to traditional medications. So thank you, Dr. Tremblay, for being with us. But before we begin, just a few administrative details. So there is closed captioning of this presentation available in both English and French. And to access this feature, you click on the closed caption button at the bottom of your screen. And from there, you can choose to translate to French if you choose by clicking on the little arrow next to the closed caption button and select the translate option. At the end of the presentation, Dr. Tremblay will answer your questions. So during the presentation, please type your questions in the Q&A box. And then at the end, we'll pose the questions to Dr. Tremblay. And so we'll hopefully have some time to answer all of your questions then. Finalement, veuillez noter que le webinaire sera présenté en anglais, mais la participation bilingue est toujours encouragée. So with that and all those administrative details, it's my pleasure to pass over the microphone to Dr. Sara Tremblay. Sara?
Thank you very much, Sharon, for the introduction, and thank you for the kind invitation. I'm gonna share my some slides. Hopefully everything works. Is that good, Sharon? Can you confirm that we see the slides?
Not yet on my side.
Oh, I can see the slides.
Okay, now it's up. There we go.
Okay, awesome. Thank you very much. So today, as Sharon mentioned, I will be talking about some alternatives to medication for treating mental health disorders. And specifically, I'll be talking about neuromodulation. So before I dig into the topic, here's a short that I'll be presenting. So first, I wanted to give a short intro on my academic journey, because you probably wonder why brought me to start using magnets to stimulate the brain. So I wanted to give just how I started working in that field. And then I'll talk more specifically about neuromodulation and how it can be used to treat mental health disorders. I will also present the development of our research clinic, because it's quite a unique clinic that we started here in Ottawa about now 7 years ago. And finally, I'll be talking a little bit about research. So I'm a scientist. Of course, I want to share some of the research we are doing. So I'll be presenting briefly the current clinical trials we are conducting at the Royal, and finally, and with some of our vision and goals for the future. So please feel free to ask any questions through the Q&A in French or English. It will be my pleasure to respond. However, I won't be able to make any specific recommendation on health related points. So I will give more of an broad overview of the work we're doing and answer more generally questions. So first, a short intro on my academic journey. So I am a licensed neuropsychologist, and my background is actually in psychology. So I was always drawn towards neuropsychology, and actually I heard that at the end of high school. I had no clue at the time that neuropsychology was actually something we could do. It was quite less well known back when I was younger, and I heard by one of the teachers that there was that job where we were studying the brain and helping diagnose for example, developmental disorders, but you didn't have to be a doctor to do that. You had to be a psychologist. And I really liked the link between being able to help people, being a psychologist, but also learning about neuroscience and the brain. So that from end of high school, that was my goal. So I started an undergrad studies in psychology in Montreal at Université de Montréal. And I was actually introduced to neuromodulation very early in my journey. So in the first year, I took my first neuropsychology class, and the teacher is my former PhD supervisor, Hugo Théoret, and he's using neuromodulation in his research. And right away, it kind of piqued my curiosity. I was very interested about the idea of using non-invasive magnetic fields to be able to study the brain and develop treatments. At the time, he was working mostly in autism, and I was working with children with autism at the time. So I was very interested about how we could use brain stimulation to study autism. So that's what I did at first during my undergrad. And then I was very lucky to be accepted into the PhD in neuropsychology. It's a very hard program to get in. They accept about 10 people per year. So this was, I was very glad to have the chance to study in neuropsychology. And I stayed in Montreal again at Université de Montréal. And so this is a PhD that we do right after the undergrad. So it's quite a long, so it's 6 years of PhD. And my work took a slight turn. So I continued using neuromodulation, but actually to understand sport concussion. And not much link with autism, but my my supervisor at the time said, "Are you interested about sports concussion?" He knew I was doing lots of sports, so I started working on that topic, and I found it really fascinating. So we were using at the time neuromodulation to understand the long-term impact of sports concussion on the brain. I started using also brain imaging, so MRIs, to also study the effect of sports concussion on the brain. And also I started working more on understanding actually what actually happens when we use neuromodulation to modulate brain activity. So I did a lot of also studies understanding the mechanism of action of neuromodulation. And following that, as scientists, PhD is not enough. We need to keep going and do postdoctoral training. So I was also very lucky to found a postdoctoral position in the UK at University College London, where I worked with one of the initial developers of neuromodulation. So that was really an amazing learning experience. So I learned over there about the most up-to-date technology. And then came back to Canada at CAMH in Toronto, where it's of neuropsychiatry. So I went from autism, sport concussion in London was more neurology to finally psychiatry. And this is where I'm still working on that field right now. And in 2018, this is where my career started here in Ottawa. So I was recruited by MHR, so the University of Ottawa Institute of Mental Health Research, an amazing initiative, which was the ERIM initiative, or Emerging Researchers in Mental Health. And philanthropy to recruit young researchers or early career researchers, start a program at the Royal. So we were many that started at the same time, which really was amazing art collaborations, all of us. And this is where I launched the neuromodulation research program at the Royal. And really my goal when I came here is I realized there was no neuromodulation or very little in Ottawa in general. And my goal was really to bring this and more importantly, to provide access to this treatment in Ottawa free of charge. I'll be talking a bit more about it later this morning. And in 2020, I crossed the river, started working also as a professor in psychology, or more specifically neuropsychology, at Université du Québec en Outaouais. And so I'm here right now. And what I do here is mostly I help generalists, and I really like being in both Ottawa and Gatineau. It allows me to develop more collaborations between the university here in Gatineau and some research centers such as the Royal in Ottawa. And this is my team. We started with about 3-4 students, and now I'm very lucky to have a large team from a bit everywhere in the world of trainees, of research assistants, staff, and postdoctoral trainees. So it's really, really great to be able to mentor all these amazing individuals. So now that you know a little bit more about what brought me to neuromodulation, now I will describe a bit more what is neuromodulation, because you're probably wondering what I'm talking about. And more specifically, I'll be talking about how it can be used for mental health disorders. As you heard before, I did mention that it can be used for other disorders, so that concussions, neurological disorders. So if you have questions about that, I'm happy to answer about other types of applications, but my focus will be more on mental health disorders this morning. And more specifically, depression. So we know that major depressive disorder is a public health crisis. So recent statistics from Statistics Canada show that about 1 in 8 adults will experience depression at some point in their life. And worldwide, the condition affects more than 280 million people. And this actually makes depression the leading cause of disability and low quality of life in the world. You probably all know at least one person who struggles with some depressive symptoms in their lifetime. So depression is a treatable condition, but for some people, conventional treatments such as medication, and this is where the title of the presentation comes from. So for some people, depression psychotherapy is just not enough, and it remains non-effective and will involve also a lot of trial and errors. So we know when we try new medications, for example, we need to wait many weeks to see if it works. If it doesn't work, then we start the same process on and on. So it can be very tiring and difficult to go through. And in fact, about 40 to 60% of individuals will remain what we call treatment resistant, meaning that they do not respond to standard treatment. And so these staggering numbers really highlight why it's important to develop alternatives to medication and some novel treatments. And this is where research also is really important to allow those treatments to become accessible. So here is what neuromodulation looks like. So in particular, neuromodulation is a kind of family of treatments that can modulate the brain. So neuromodulation, either through electrical fields or magnetic fields. And in today's presentation, I'll focus on one specific type of neuromodulation, which is called repetitive transcranial magnetic stimulation, or rTMS. So RTMS, as I mentioned, is a type of neuromodulation technique that can directly stimulate the brain, and specifically directly stimulate circuits in the brain that we know are involved in a specific condition like depression. And it's done not by a big magnet that's stagnant, it's done actually by producing brief and painless magnetic pulses. So I'll be showing a short video so you can see a little bit what it looks like, but to really understand, I feel the best way is to actually feel it. So it feels like a bit of a tapping sensation on the scalp. So we position what we call, I'll try to see if I can use a pointer. So we position what we call a magnetic coil, and the magnetic field or the pulses will be centrally at the center. So it's very focal. We can only stimulate one network or circuit at a time. And so it's the magnetic pulse is sent at the center. And what's unique about magnetic fields, it's not deviated by the skull or the scalp. It just directly goes into the brain and modulates activity in a quite painless way. So some people might feel a bit more of a sharp tap, but it remains quite painless. And so for typical treatments, the person will come in the clinic daily from Monday to Friday for 4 to 6 weeks. So typically treatments used to be about 45 minutes daily session, so quite long, like about an hour in and out of the clinic. But with recent advances in technology of TMS, we can now offer the same treatment for only 3 minutes. So it's a slightly different pulses, but we can get the same clinical effects in 3 minutes. And the specific new treatment, I was trained in using it in London. Actually, the mentor I worked with was the one that developed that new treatment. So it was really great to really learn more about how this new treatment works and bring it here in Ottawa. So once the person is receive the treatment, so now it's about 3 minutes. So in and out, it's about 15 minutes. They can go on with their daily activities. So there's no strong side effect that the person wouldn't feel good, for example, to go back to work if they're working. So although it's relatively time consuming, so coming daily for 4 to 6 weeks, I like to say that I think it's the biggest side effect of neuromodulation is time commitment. It has, though, the advantage of producing very little side effects compared to medication. And it's not that new. So RTMS has been approved by Health Canada to treat depression since 2002. So it's been around for a while, and we know that it works for a while. However, it's not yet covered in Ontario. It's covered in some provinces, for example, Quebec and Saskatchewan, but not in Ontario. So it does show how long it can take for technologies to actually be integrated in standard of care. So here in Ottawa, the only way to get access to RTMS is either going private, but it's quite costly, so not everyone can afford going private. Or this is where the work I'm doing comes in through research. So via clinical trials, we're able to provide the treatment free of charge, thanks to funding from great grant agencies, also some funding from the Royal and some funding from philanthropy. So it's really a teamwork to be able to bring this treatment forward. So this is a bit more technical. I'm not going to go into details, but I like to present how this was developed. So how did we start using magnets to stimulate the brain? And it comes back quite a long time ago. So TMS is based on a physics law that's called the Faraday law, in which, like in simple terms, this law shows that if we use a an electrical current, it will create a magnetic field, which in turn will create an electrical current in a conductor. And the brain for TMS is the conductor. So we send an electrical current, it delivers a magnetic field, and in the brain, it becomes electrical current again. So that's how we can modulate brain activity. So this was discovered in 1831. But it was a little bit forgotten. So in the 20th century, we were more interested about electrical fields. So you probably all heard of electrical convulsive therapy, for example, or ECT. So it is based on electrical current. So that was developed around the middle of the 20th century. But there was that magnetic field in the background that could have been used, but that wasn't yet really in actuality. But it's in 1985 that researchers in London, in the UK, developed the first TMS machine. So it's quite recent when we think about it in terms of technology. And only a few years later, this is when scientists started discovering that when they were sending pulses in their participants, people would say, I kind of feel a bit better. It's like my mood is elevated. And so it's a bit by chance that scientists noticed some mood improvements in participants and started studying that maybe we could use that to treat depression. So it's really in the 90s that there was a lot of studies on depression, which led to Health Canada approval in 2002. In the US, it was a little later. In 2008, it was approved by the FDA. So this is an old video, but I like showing it because it really, I find it exemplifies quite well how the treatment is done. So this is actually my former PhD supervisor during his postdoc training at Harvard. So it did change a little bit, the technology since then, but it's still very similar. So when we stimulate motor regions of the brain, so the regions of the brain that control the hand, for example, we can actually make the hand move. So it's one of the most, I find, obvious demonstration of how with TMS we can stimulate brain activity and actually induce something in the brain. So in that video, you'll show the motor, you'll see the motor cortex being stimulated. So you're gonna hear some pulses. So these are the magnetic pulses. And you're gonna see the finger move. So it's painless. It feels a bit like a reflex, when you go to the doctor's office, they look at your knees. And we can measure that contraction. And this is a bit of another way to use TMS, but that allows us to also measure brain activity to see how well the brain functions. But this is something we actually do in people that come in for treatment with depression. We call it calibration. So we stimulate their motor region because we have this output, we have this hand movement that we can quantify. So we calibrate the intensity of the machine to the minimum intensity to make the hand move. So this is how we can personalize treatment intensity to each individual. So now you're probably very interested about, so I said little side effects, but there must be some. What are they? So the more common side effects are some mild discomfort or pain at the stimulation site, depending on what condition we treat. And even within treatments of depression, there's different brain regions we can target. And depending on that region, it can create more discomfort than other sites of stimulation. So the most common side effect is just that kind of sharp tap that people will feel, but it stops when stimulation stops. So it's only 3 minutes of stimulation, and during that time it can create a bit of discomfort. Some people do report some kind of muscle type tension headache after stimulation. What we see is it's often in people that have migraines that are more likely to feel a bit more some headaches after stimulation. But typically with Advil, Tylenol, so over-the-counter medication after treatment, this subsides quite fast. And typically we see that over the treatment course, these side effects do tend to decrease. So like the brain gets used to stimulation. It can induce some facial muscle twitches because when we stimulate in depression, we stimulate more in the frontal lobe, so this the front of the brain. And we do stimulate at the same time some little muscles at the surface. So it can create a muscle twitch when we stimulate. But again, this is only when the pulse is sent and it stops afterwards. And some people may feel a bit of dizziness or lightheadedness right after treatment, but this is less common. And then we're going to move in the very much less common side effects. So less than, I'd say, 1 to 7% can have fatigue, some agitation, some migraine, aura, tinnitus. So we do keep track of people that do have prior tinnitus. Vomiting, I honestly never seen that. I think it's reported in some studies, but I've never seen that. Abnormal sensation, I've never seen it as well. And syncope, what we've seen is some people can be nervous in the first few days. So if people are more likely to have syncope, they may experience it, but we've thankfully haven't also had anyone experience that. Again, some rare but serious side effects, less than 1% can be actually worsening of symptoms, and that can be with actually any treatment. And finally, a very rare but serious side effects is a risk of seizure, but it's less than 0.1%. And it's actually the same prevalence of antidepressant medication. Antidepressant medication have also a very, very low risk of seizure. So how we manage that is we make sure that people with any history of epilepsy don't receive treatment. So this is one of the main contraindications to really prevent any risk. Some of other safety considerations are any implants, so cochlear implant or metallic implants. So if for some reason there's a metal plate implanted on the cranium, for example, the person will not be eligible. Or pacemakers, because we wouldn't want to alter the functioning of the pacemaker. So we typically, for anything implanted, we're very safe. And as I mentioned, epilepsy or an history of seizure is a contraindication. And in terms of cognition, what we've seen in now quite clearly in the literature is that it doesn't have any adverse impact on cognition, like, for example, electroconvulsive therapy can have. On the opposite, a lot of studies show positive effects on cognitive function, and it's studied for dementia, for example, for treatment of dementia at the moment. So I spoke more generally about the fact that it's approved for depression, but I wanted to talk about kind of sub populations. So, for example, in geriatric depression or depression in older adults, what we see is that it has a similar efficacy as adult population. In some cases, they may need a bit of a higher stimulation intensity, but we've seen in our clinic very good results with people of all ages, with adults of all ages. In youth depression also, it's generally well tolerated, but like any treatment for youth, we're very careful. So it's not yet approved by Health Canada, but you'll see a bit later in the presentation that at the Royal, we started offering it for adolescents 16 and above. For bipolar depression, sorry, I see a typo here. So the efficacy is not as well established, but there are many trials that show that it's also efficacious. So at the Royal, we also offer it right now for people that have depression or bipolar depression. And for depression with some psychosis, so it can happen sometimes in the course of depression that the individual would develop some, what we say, features of psychosis. In these cases, it seems that RTMS is less effective. So typically, we will refer these individuals more to ECT or electroconvulsive therapy because it's been shown to be very effective for that specific condition. And before I move on to talking about our work at the clinic, I wanted to just give a brief overview of what TMS is approved for beside depression. So it's been recently approved by Health Canada for obsessive compulsive disorder. This is very recent, so we don't yet have it at the Royal. Smoking cessation as well, again, very recent. But we're working towards developing some research to offer it through at the Royal for those two conditions. For schizophrenia, it's still under investigation, so not yet approved. Same thing for post-traumatic stress disorder or anxiety. But we're working also towards developing some research projects to offer it for these conditions through clinical trials. Now, briefly, the development of our research clinic. So I present this because I think it's a good example of how we can bring clinical work and research together to offer a treatment to the population. So as I mentioned, I arrived in 2018, the summer of 2018. So in the first year, we really worked toward getting our first machine. And also, we did a lot of consultations with other groups to design the first clinical trial to make it as inclusive as possible. We wanted to offer treatment. That was the main goal. And of course, do research to improve treatment. But really, the focus was to offer it through a clinical trial. And in 2020, January 2020, we launched our first clinical trial. But then COVID hit. So we had to stop for a bit more than a year. But during that time, we were able to get a second machine. So when I talk about a machine, we can treat with one machine about 14 to 16 people a day. So the more machines we have, the more we can offer it. In 2021, we received some very generous philanthropic support that really allowed us to expand and officially launch the Royal Neuromodulation Research Clinic. In 2022, we received some more support from philanthropy, launched a second clinical trials. In 2023, we got a third machine and launched a third clinical trial. 2024, we did renovations to the unit, expanded our team some more, launched a fourth clinical trial. We don't have 2025 here in yet, but a lot already happened in 2025. So we received some support from the Royal to expand our services. And we also launched a fifth clinical trial. So it was a very rapid expansion, but it also allowed us to treat, to have a rapid expansion of the number of people we were able to treat. So here's a very short video about our clinic with me that tried to be a comedian, which is not super good. But so this is kind of showing what would be the journey of someone coming to get treatment. So you saw the brain imaging center. So something very particular about our clinic is that we have the people's brains scanned before treatment, and that really allows us to bring the treatment a step forward to personalize further treatments, because it's not necessary for treatment to have a brain scan, but it allows us to make it more efficient. So you're seeing here a muscle contraction. So this is what I mentioned about calibration. The The headband that you see here is a system that we call a navigation or neuronavigation system. It allows us to be very precise in which region of the brain we target. This is actually used also in neurosurgery, so it's really, really precise. And you can see here the neuronavigation software. So this is what a TMS machine looks like nowadays. And so we see here the motor region of the brain being stimulated. In some of our studies, we try to predict who's more likely to respond to treatment using this cap. So it has electrodes that allows us to measure brain activity before and after treatment. And this is what a treatment room looks like. So when the person comes for the daily treatment, we do take some measures to calibrate the navigation system. We position the stimulating coil, we send the treatment for 3 minutes, and then we ask them about side effects, and it's done for the day. Oh, there's a bit more to the video. Okay. In some cases, we do stimulate both sides of the brain, so depending on the type of treatment we do. So you can see here live the coil being targeted to the brain. So in numbers, you can see on the left side kind of the evolution of the number of treatment we've been able to give in a yearly basis. So last year in 2024, we had 62 individuals come for treatment. It might seem like not that much, but it's quite a lot because in a lot of our protocols, we follow everyone for 7 months. So people will receive 4 to 6 weeks of what we call acute treatment. And then we do a maintenance phase of 6 months in which people come back at a reduced frequency for treatment. There's not the numbers for 2025 yet, but we will be above the numbers in 2024. So we've seen really a steady increase. On the right side, you see our remissions and response rate. This is something I didn't mention previously, but for typical RTMS treatment, we expect about 30 to 40% remission and 50 to 55% response. So we see that these numbers in our clinic are above. And while we're doing research to better understand why, but we think that a lot of it is due to the fact that we use the most recent technology. We have the brain scan, the navigation system. So we really use all that's available to make treatments as efficient as possible. And we see it in our response rate. So it's quite amazing to see that 50% of people coming to the clinic are in remission after treatment. So this is something we're very happy about. To be able to offer a treatment that's that efficient. And a lot of people that come to us have tried a lot of things before. And one of our goals is also to bring TMS, to make it available as early as possible through the journey. So this is our team. So we have 3 psychiatrists that work as part of the team. Now 2 psychiatrist fellows, a manager, and 3 technicians that work to make those treatments possible. I did add that just if there was any question about how to get access to our clinic, I can share the slide deck afterwards, but this is the link to our clinic. So to be referred to our clinic, what we need is a referral form to be completed by a physician, so either a psychiatrist or a general practitioner to access the clinic. And in terms of clinical workflow, so how does it work to receive treatment? So first we review the referral, and then the person will meet with one of our team psychiatrists to see if it's safe and to deliver RTMS. And then we're going to have a discussion. We have a weekly team meeting in which we discuss each cases and see if it's appropriate to deliver treatment. Then there's a clinical interview oftentimes an MRI of the brain, and then treatment. And so this is a time focused treatment. So at the end of treatment, the person is discharged from RTMS, and we send treatment recommendations to the physician that referred. Before wrapping up, so I see it's 10:40, so I'll take about 5 more minutes to present our current clinical trials, and then I'll happily take any questions. So we have a few different trials, which is really great now because we have different options. We used to have only one trial, and now we have different options to offer to people that seek RTMS treatment. So the first one we developed is called a naturalistic trial. It stands for a trial that's less restrictive than typical clinical trials. So that's what naturalistic stands for. So meaning that we accept people that have other mental health disorders, for example. In some clinical trials, we're more strict in who can participate. So for the naturalistic trial, we really wanted to design something that would look like what TMS would be in the community. So we offer 4 to 6 weeks of daily treatment, as I mentioned before, 6 months of maintenance, and we study many different aspects, so like sleep quality, quality of life, anxiety. We study also lifestyle and brain activity. So this is for that trial, our outcome so far. So we've recruited so far 140 individuals. So we're towards the end of that trial. We're aiming for about 160. You've seen the cap with some electrodes. So this is what it's for. We're trying to understand how the brain changes after one treatment or at the end of treatment can help us understand who's more likely to respond. Because even though we have 60% of individuals that respond, we still need toward the 40% that don't respond to offer an alternative. Here you see Arthur Chavez, who's worked as a postdoctoral researcher in my lab and now joined the team as a scientist. And he's also an exercise physiologist. And Arthur was very curious about how physical activity levels in our clients was linked to their response. And what we saw is that people that are physically active respond much better to treatment. Might seem obvious, I didn't think we would see such big effects. So it seems like physical activity is good for the brain, just in general. And even if in people that have depression, it can help them respond better to other treatments, makes their brain more likely to respond. So now we're starting a new study, actually next month, in which we're going to recruit people that are physically inactive with depression and have them go through an exercise intervention that's personalized, and then TMS to try to see if we can increase the response. I might skip this one. We also use the brain imaging scanner to better understand mechanism of action. And very interestingly, we also use it now to personalize even more treatment. So now we're able to, for each person's brain, find the target that's the most likely to be effective. So we're testing this in a clinical trial. We're comparing if it's more effective that we typically do right now in collaboration with Dr. Larry Twiminen, who's a scientist also at the Royal. I mentioned earlier that we also now offering it for youth with depression. So this is a pilot trial that we're trying to see if it's feasible for us and if we're going to receive referrals for individuals that are 16 to 19. And part of my work also is on developing treatment innovations. One of it is robotic TMS. So instead of having someone hold the coil, it's a robotic arm. So I just received the first system here in Gatineau, actually. So we're testing it in different ways to eventually bring it to the Royal also for treatment. And to end with our vision and goals, so it's been only around since 1985. There's so much more to do. But what we know is that RTMS is an effective treatment for depression. It should be more accessible. We have now shorter protocols with great potential, and I see it really being more and more integrated with other treatments just as an option. So I really am a strong advocate for increased accessibility of this treatment. There are, like anything, current challenges. We need to do better to identify who's more likely to respond, also better understand the factors that lead to remission, and also finding ways to select the optimal parameters and to develop biomarkers for prognosis. And in terms of our vision and goals, so we want to keep expanding the clinic. We want to further involve clients and families to help shape the future of the service. We've recently created the interventional psychiatry program that brings together neuromodulation with other techniques. So I think it will be really key to make this more accessible. We created also a fellowship in collaboration with U Ottawa, so a fellowship in interventional psychiatry. So we have our first 2 fellows that learn TMS, and I also think this is an important part. I think physicians need to be taught TMS so that also they can integrate it in their practice in the future. And we're working on some grant applications to be able to offer services also for other mental health disorders now that we have established a service quite well for depression. And I want to end on a couple clients' testimonies. So of course, it's not working for everyone and it's not miraculous, but I think it's a treatment that is effective and that needs to be accessible. And when it works, it can really be life-changing. So for example, one of our clients told us some of the questions I was asked after treatment were about feeling sad. And I had to really think about it. And I said, no, I'm not sad like I was. There are sad things in life, but then you go on to think of other things. And that's the difference. My anxiety and worry about how I'm going to carry on has gone away. And lastly, another client told us, since the treatment have been about able to get out of the house and do social things, I look back and say, wow, I felt that way, that bad. I can't believe it. RTMS saved my life. So as you can see, for some people, really, it can bring light and really make their brain be able to function well again. And this is a teamwork for sure. So I want to make sure to thank everyone, all the participants, the donors, the clients that participated in our study, and the funding agencies. Before I can take on some questions.
Okay, well, thank you very much, Dr. Tremblay, for such an informative presentation, and it's certainly an area that gives hope to so many people. So the first question is, j'aimerais savoir quelle est la durée de l'efficacité à la long terme de ce traitement. So in other words, how long does it last?
Yes, can you still see me? I suddenly
I can see you.
Okay, good. I suddenly lost Zoom. Okay, it's fine. So how long does it last? That's a very good question. And that's kind of one of the fields that we're still learning more about the duration of treatment. What we know from studies that look more of a long term is it can, for some people, last very long, from others 6 months to 1 year. So we're now developing protocols to know when to re-offer treatment, kind of as a maintenance idea to maintain the effect. So we're starting to see people that responded well about a year ago come back to the clinic. So likely there would need to be a few courses of treatment. Well, we don't know yet if maybe after 2 or 3 you don't need any further treatment. So we're still learning about that.
Thank you. There's a series of questions about access. Maybe I'll go through them and then I can remind you if you wish as you go, but is it eligible for people both in Ottawa and Gatineau? Maybe we'll just go one by one. Is it for both? Are both eligible?
Yes, we offer it for both Gatineau and Ottawa.
Great. And what's the time frame from having a referral to treatment?
So very lucky right now to have no wait list. So I say that it might not last forever, but right now it's very quick. So typically, if we receive the referral, as I mentioned, we review it, and then within 2-3 weeks, there's an appointment with a psychiatrist, and then we discuss as a team, and again within 2 weeks, we're typically able to start treatment. So within a month to, like, really worst case would be 3 months is access to treatment.
That's wonderful compared to many other programs. Um, in your numbers, it was noted that so many people applied and then so many people were accepted, and the number was almost half or something. Why are people most commonly rejected from their application?
Um, that's a very good point. And one of the main reasons was sometimes it's just not safe. So I discovered that metallic implants are more frequent than we think. So so for some people that was safety concerns. And it's still research. So even though we're trying to be as inclusive as possible, for our research trials, we ask, for example, for people to maintain the medication during treatment. Some people cannot do that. So these are the most common reasons, I'd say, is that it's either it's not safe or in the end, they're not eligible for research. And this is where we're trying to also have a clinical only branch where we can now offer more widely treatment.
Someone also asked, will you be doing a sleep study? I know sleep was one of the things you noted in your presentation along with others. Is there a study dedicated to sleep?
Yes, actually, we have sleep components in many of our studies because we know insomnia and sleep disorders are very closely related to depression. So we have one the naturalistic trial in which there's a optional component where people can get a full sleep polysomnography at the sleep lab at the Royal to understand the effect on sleep.
One person asked if they're not able to get into the clinical trial, how much would it cost for a 6-week course of RTMS
It
privately?
depends on the clinic. So I want to make sure my numbers are accurate, but it can range from 10 to 20,000, I think, for not including maintenance.
Right. So I know that it's clinical trials and it's now eligible for by Health Canada, or approved, I should say. Any idea when OHIP or when it will be covered by OHIP or private healthcare plans? Is there an application been made, or what's the status on that?
I'm hoping it's coming, but like anything, like I'm not involved with those discussions, so I don't know when it's coming, but I'm hoping this is going to be accessible soon to people in Ontario, given that it's accessible in other provinces such as Quebec. But it needs, I think it's important that it needs to also be accessible, not only approved, because for example, in Quebec, it is reimbursed by the RAMQ, but it's still not that accessible. For example, in Gatineau, I know they're working towards getting a TMS machine, but it's not yet available. So I think we need to think about both sides of things, accessibility also.
And can you have a referral? You had mentioned that you can have a referral from a GP or a psychiatrist. Can you also have one from a psychologist, or does it have to be a medical doctor?
It has to be a medical doctor because it's a medical treatment and there can be some contraindications that are more medically related. Yeah.
Does this work for people with dementia?
There are lots of studies on RTMS for dementia. It's still experimental, so we don't have yet kind of a gold standard treatment that's being approved. So the study shows right now that in some cases it can improve symptoms and slow progression, but like many of the treatments for dementia, doesn't seem to stop, progression of symptoms.
There's a lot of questions about people currently taking medications and whether it be high blood pressure for some other mental health issues or other treatments. I guess you mentioned this a bit. Do they have to stop those drugs? Would they be ineligible? Because there's a lot of questions around that.
Yeah. No, they don't have to stop. So what we ask is just that it's stable during the course of the study, just so that we can really know that it's the effect of TMS and not a new medication, for example, that would have been prescribed. So we do, this is also why the referrals come from GPs, and we do take time to review the medication list to make sure everything is safe. But typically there's no issue.
And a couple people asked about the QR code, but just so you know, we're going to send out the deck afterwards, and the QR code will be in the deck, and that should be out in the next couple of days. So that's an answer to some of the questions. Then there were some questions about eligibility, like is there a maximum or minimum BMI? There was other questions about is neurofeedback part of the process? So I think that's about the last two questions that we have time for. So I imagine the BMI part would be in the criteria in the document that would be linked in the QR.
Yeah, exactly. Depends on the project. It depends if imaging is involved. For example, we do have, I don't remember on the top of my head what's the criteria, but for example, for exercise, there is one criteria related to BMI, but we tend to be as inclusive as we can. So
Right.
there should be at least one study that can work. For neurofeedback, not yet. So there's a lot of different combinations we could do. This is one of them. So I think one of the future of neuromodulation is also in combination with other treatments. And this is the next phase of our studies as well.
And there was two more questions, but I don't think we have time for, but just maybe there's something that for you to think about. One was they're already a patient at the Royal, and they wondered if they could be streamlined into this program, being already treated for treatment-resistant depression. But I imagine they should just ask their psychiatrist about this. That would be one thing. And then there was another question about
email me, or I think
there.
I
Good.
will
Okay.
add my email. I think it's
Part
now.
of the follow-up document. Great.
Yes. And the short answer is yes for them.
Okay. Oh,
There
that's
is the fastest pathway.
And the final question, and maybe that can be something in the post piece too, is where can they get it in Montreal if they want to pay? So that was a question. So
At the SHIM, it's available free of charge, and the MUHC as well. But yeah, they can also email me for more details. There are private clinics as well.
well, again, thank you, Dr. Tremblay, for explaining this novel and innovative treatment to us today. For me, it's really groundbreaking because some of these treatment-resistant mental illnesses are so challenging. And so this is wonderful that people now have hope. So thank you so much for that. And as I mentioned, soon you'll receive an email that'll contain the recording of today's session. And just a little paid political announcement for our association. Our MECA recruitment drive is now on. And each time you refer someone who joins the association until November 21st, you'll be entered into a draw to win a grand prize of a $20,000 travel voucher, courtesy of Colette, $5,000 in spending cash, courtesy of Bel Air Direct. So think about it. If you know somebody that you think might benefit from our association, please refer their name. And don't forget to look at our upcoming webinars that are on our website, and all this information will be included in our follow-up email. So once again, thank you, Dr. Tremblay, and thank you for everyone attending today. It was most informative. All the best.
Bye, thank you.